Hi everyone, I'm Dr. Suhas Radhakrishna, otherwise known as Dr. Rad for the Painted Turtle community and for the Rady Children's Hospital. I'm a pediatric rheumatologist at Rady Children's Hospital in San Diego, and I have been a volunteer doctor at the Painted Turtle camp since 2011. And I love camp, I love being there and seeing the kids having so much fun. And I really am sad that we're not doing that this year, and hopeful that we'll be back in action again next year. So the camp staff has asked me to put together a talk for parents, and I thought it would be good to talk about COVID a little bit more. I'm sure you've been pretty well exposed to a lot of information about COVID. Hopefully this talk is going to just maybe reiterate some things and clarify a few things. This is from the pediatric rheumatology perspective. I'm not an infectious disease doctor, but I've been following this pretty closely from the beginning. So the outline of the talk today is just basically going to cover COVID symptoms, mainly focusing on the manifestations in children, but I'll do a brief review of the symptoms in adults. And then I'll spend a little bit of time talking about MIS-C or MIS-C, which is the multisystem inflammatory disease in children. So this is what happens in some very recover, and then a few weeks later end up getting a multisystem inflammatory disease. And then I'll go into the more recent recommendations from the American College of Rheumatology regarding how we should be managing patients with rheumatic disease in the time of the global pandemic. And I'll end with a few comments about where COVID is right now. So this is not going to be an exhaustive. There's so many different things that we could talk about and I could go into, but I wanted to just give you a few of the highlights and the important things that are coming. So let's talk briefly about COVID-19 symptoms in adults just for review. As you all probably know, the majority of patients are going to come in with fever and cough, with body aches, which is what we call myalgias, and shortness of breath in about 30% of patients. So the adults really come in with more of respiratory symptoms and fevers, body aches. About ARDS, typically during the second week of illness, and that is where the lungs get severely affected. That's acute respiratory distress syndrome. Now overall, if we're going to look at data from China, and this has pretty much been reproduced in other countries as well, 80% of people who get COVID are going to have mild symptoms. Maybe 14 are going to have more severe symptoms, and about 5% of patients may require ICU level care. As you probably have heard before, patients with more severe disease and including death tend to be those who have what we call comorbid conditions, or what we say typically hypertension, cardiovascular issues, lung issues, and so forth. I want to spend most of our time really focusing on pediatric COVID. So, the initial case series from China did shed light on the idea that children were a small percentage of the total number of COVID cases. And this has been true in multiple series across different countries, that about 1 to 5% of the total number of cases end up being in pediatric age groups. In the United States, it's about 4.2% of total cases. If we look at the age distribution, it's pretty even, although there's a little bit of a predominance in the older kids. So kids older than 10 are the ones that are being tested, let's say, who are presenting with more active symptoms typically. In addition, there's more and more data coming out now that's suggesting that racial and ethnic minorities may be affected more disproportionately. And I think it still remains a question, but it seems to be the case that this has more to do with social or economic factors than it does to do with the biology of, whatever these ethnic differences are. But still, there's a lot being looked into at this point. We don't know the answers of that yet. So what does COVID look like in younger children? So if we look at the kids that are under age 10, I've listed out here a chart of the symptoms in terms of more frequent to less frequent. So going through this, you'll see that basically fever and cough are the main symptoms for the majority of patients, and body aches and headaches as well. Some patients, about 15%, are going to have complaints of nausea, vomiting, and diarrhea. Only a small number are going to have runny nose, which is what we call rhinorrhea, 13%. And only 7% with shortness of breath. And that very rare thing, the loss of smell or loss of taste, is occurring in about 1% of young children. If we look at kids over 10 years old, it's a pretty similar distribution of symptoms overall. There's a higher incidence in this of loss of smell or taste. Up to 10% of kids are showing up with that. But still, the majority of symptoms are going to be fever, cough, headache, and body aches, what we call myalgias. And then about 15-20% of kids are going to have some diarrhea or abdominal pain symptoms. If we look at this data from China, from the initial case series that came out, on the left column you'll see the age groups broken down, and then mild, moderate, and severe disease across the top of the table. And overall, you'll see that if we really focus on the severe and critical cases, that's actually going to be more the younger children. So kids under 5 are the ones who are maybe less likely to be tested and reported, but more likely to have more severe disease. And that probably makes sense in terms of their physiology and the vulnerability of that young age population. So this is the question that we've all been trying to understand in pediatrics. What is the risk for children with autoimmune diseases or children who are on biologics or drugs like methotrexate? And up till now, there hasn't been tons of data out there that I've been able to see. I did find this on the CDC website, and this just is recently published, June 27th. So this is really, really helpful, I think. It's a very busy slide, but what you'll see in the light blue color is pediatrics cases, and then the dark blue is adult, and the red is pregnant, and that you can kind of keep separate for now. So we're going to focus on the light blue color. So all the way at the bottom of the slide, you see that there's an option of no known condition. So this is previously healthy children. So that makes up the majority of children who are hospitalized for COVID-19, because that's kind of what we care about more. Not necessarily cases, but what are the hospitalizations looking like? So 48% of the kids with COVID underlying condition issue, it's not immunosuppression or autoimmune disease. It's actually obesity. So higher body mass index is a risk factor in pediatrics just as it is in adults. And that seems to be much more of an issue than it is for the immune system issues. So 38%. So I've put boxes around the other ones. And if we look at immune suppression, 5% of pediatric cases had a history of immune suppression, and only 0.6% reported autoimmune disease in their database. So I'm not sure what the 5% that are immunosuppressed that don't have autoimmune conditions are. So I'm sure the number is somewhere in between there. If you look at asthma on the top there, it's 14%. So it's actually, that's a higher risk factor than underlying immune disease, it seems to be. And this is data from the New England Journal of Medicine. So this is one of the things that came out in April. That was one of the things that really helped me sleep better at nighttime in terms of taking care of our patients. This is the data from New York City. And Here, they reported 86 patients who had a history of a rheumatic disease or an autoimmune disease, who were on medications, who were suspected of having COVID-19 or who were confirmed to have COVID-19. And they broke it down, if you look at the table, into ambulatory patients, so that's outpatients, and then hospitalized patients on the right. So here you see they had representations of patients with psoriasis, psoriatic arthritis, rheumatoid arthritis, ulcerative colitis, Crohn's disease, and ankylosing spondylitis. So different forms of arthritis, and we don't see lupus, we don't see other rheumatic diseases in this series, unfortunately. So what they basically showed here is that, well, I'll cut to that in a minute, just looking at the medications that these patients were on. If we look at methotrexate, 20% of the total group were on methotrexate, a little bit higher in the hospitalized patients than the not hospitalized patients. Patients with biologics, so a good number of patients on biologic drugs here. 62 out of the 86 different biologics down here. So this is tumor necrosis factor inhibitors would be your common ones in pediatrics, like Enbrel and Humira and Remicade. We still don't have many patients taking these other ones, the IL-17, IL-23. This would be, IL-12-23 is Stelara, ustekinumab. And we have only a very small number of patients on these other drugs here. JAK inhibitor would be Xeljanz or tofacitinib. So here's the thing. It gave us some idea that patients even on biologics are doing fairly okay if they do get COVID-19. We still haven't seen anything like this really published for pediatric rheumatology yet. So one thing that you're going to come across in readings about COVID is this R0 concept, or R0. And I've seen this here and there. I thought I'd just throw this in. This is basically the number of people that one sick person can infect on average. Okay, so this tells you how infectious this disease is. And then compare across different diseases. Like measles, one person who's infected can infect 18 people on average. The R0 calculation for COVID from the initial series is around 2.28. So one infected person can infect about 3 people. That's what's predicted right now. And this is going to shift and change based on social distancing issues. And it brings up this idea of asymptomatic carriage. So these are people that are, it's estimated that 20 to 40% of the population could be in this category, where they have very mild or no symptoms at all. And this is leading to the idea that we should be testing more patients in general to understand what the baseline rate of infection could be and how this disease may transmit to people who are more vulnerable. So Rady Children's is doing an initiative right now for a lot of the outpatients that have come in. They are giving an option for parents and families to get tested, even if they have no symptoms. And this should hopefully help us to inform this data better. So now we'll switch gears to the idea of MISC. You probably heard about this, the hyperinflammatory syndrome, the cytokine storm that occurs in some children. It's a very rare phenomenon, but I wanted to go into that a little bit more. So what's happening here is that patients have COVID infection, and they may have a relatively mild infection, and usually they recover from that infection. During that time, they could be PCR positive with their nasal swab for COVID. And then 3 to 4 weeks later, there seems to be an overactive immune response that may be building this entire time, we don't know. But it manifests 3 to 4 weeks later with a set of symptoms that have been labeled MISC, Multisystem Inflammatory Syndrome in children. At this point, a lot of these patients are negative for COVID testing in the nose, PCR, but most of them are going to be antibody positive. So that shows that they don't really have the COVID infection anymore for the most part, but their immune system response to COVID is what's causing all this damage. And remember again, the vast majority of children with COVID are going to have no or mild symptoms. MIS-C is a very, very rare complication. So let me just give you a picture of what this looks like instead of looking at tables. What it seems to be for the most part is that patients come in 3 to 4 weeks after their infection initially with fever, persistent fever daily for about 4 days, accompanied by significant GI symptoms, so diarrhea or abdominal pain. And this can be so bad that in some cases that patients have been taken to the OR thinking that they have appendicitis. So it's a more significant abdominal pain and fever. And along with that, some of these children are developing rashes of various types and redness of the eyes. And this is what allowed or caused some of the doctors who initially described this to say this was similar to what we had seen in Kawasaki disease. And I'll show you a slide on that. So these patients come in with fever and diarrhea and abdominal pain and sometimes rashes, but some of them are at risk of significant inflammation, particularly to the heart. And that is inflammation of the blood vessels of the heart, which could lead to a risk of blood clots or heart attacks. In addition to that, because of the immune system's response, some of these patients are also showing up or developing over time very low blood pressure, which we call shock in medicine, which can then cause multi-organ damage. So if your blood can't reach the organs because the blood pressure is so low, then it starts causing a lot of damage. In addition to that, we see a lot of inflammation throughout the body in these patients. So sometimes it's the inflammation, the immune system going after these organs as well. Fortunately, based on the case series from New York and Italy and multiple places around the world, we've found that the treatment of immunosuppression, if MIS-C is identified early, tends to come with things like IVIG and steroids, and sometimes biologics like anakinra. These children tend to do very well for So just a brief aside talking about Kawasaki disease. You might hear this people saying Kawasaki-like syndrome. And that's how it was first described in some places. So just to kind of review that or talk about that for a second, Kawasaki disease occurs usually in younger children, usually less than age 5 typically. And they come in with fever persisting for more than 5 days, and they have at least 4 of the following symptoms. They have cracked lips that look like this. They have a strawberry. They can show up with swollen lymph nodes on their neck, puffy fingers and puffy feet. This is just an inflammation of the eyes. And the deal with Kawasaki disease is that some of these patients who present with these symptoms are also at risk of inflammation of their heart, specifically their arteries of their heart. They're called the coronary arteries. And they can become very dilated, and they can become at risk of having heart attacks. And we established in the 1980s, I believe, that IVIG is a very good treatment for this. And some of these patients also receive other biologic treatments too nowadays. So there are some similarities between how Kawasaki disease can present and how MIS-C is presenting. But the differences are that usually they don't have all 4 of these things or more than 4 of these things. And that these patients with MIS-C tend to be older. They're usually late, school age or teenage patients, not young patients. So this is just a review of the different symptoms that initially show up as MIS-C, a few weeks after COVID. Persistent fevers, GI symptoms, again, these are the common things. Rashes then, redness of the eyes. Mucous membrane involvement means like those Kawasaki symptoms, like the lips and the tongue. Here's another one that's being recognized is neurological symptoms. So our more significant case that we had at Rady Children's is a young boy who presented with balance problems. The rest of the symptoms are actually minor for the most part. And then again, just to review the clinical complications, Now, this all depends on what series you're looking at and what data you're looking at. The initial data show that were published were showing 50 to 80% of the patients in shock. We're now recognizing that MISC is much more of a spectrum, and that we're seeing a lot of very mild patients for the most part, and relatively few sick patients who have really significant cardiac involvement or significant shock. So based on these reports, the CDC came up with this case definition. And basically what it is just a summary. It says that kids coming in under 21 years old come in with fever. They show lots of inflammation in their blood tests. They need to be hospitalized typically because of that. And they have multisystem organ involvement. So they have inflammation or damage in their heart, their kidneys, their lungs, their blood cells, their GI system, their skin, or the brain. And we've ruled out any other possible diagnosis. So here's where we have to be really careful. We don't want to lump everybody who shows up with fever as having MISC nowadays. And I think that's also becoming more and more recognized, that there are kids who have inflammation because they have a UTI or they have some other infection. And we have to be really careful before we go and label them as having MISC. And these patients have to show that they've had a history of exposure to COVID or they're positive by PCR, CDC definition that we've been trying to use. So what do we know about the risk? What we're seeing so far is that the majority of kids, just cutting to the chase here, are previously healthy. So 80% of these children don't have any underlying medical issues. What does seem to be a common thread again is a risk based on obesity or higher body mass index and asthma. So many of these patients were in a higher weight category. Again, here the age is from 9 to 11 typically. So it's more the older kids. And there may also be here a racial or ethnic prevalence that's different. The London series, which is the one that first came out, that was the first thing that sort of described the syndrome. The majority of the patients are African or Afro-Caribbean in origin. And here, I think we'll also potentially be seeing a higher population incidence in the Latino population. That still remains to be seen. Okay, so I'm going to switch gears to my final section, and this is what the American College of Rheumatology has been recommending for pediatric rheumatology patients. These guidelines just came out pretty recently based on expert input from several different docs. Ultimately, I would say talk with your pediatric rheumatologist. Every case is different, every situation is different, everyone's disease is manifesting slightly differently, and they may be at a different point in terms of how active or not active they are, at what point they are in their growth, factors in the family. There's many different things that we would take into account in deciding how to manage medications. But in general, this is the guidance provided by the American College of Rheumatology. First of all, very obviously, keep doing your social distancing, hand washing, and mask use as much as possible. It doesn't mean you have to stay indoors all the time, but keeping some distance and using those masks is really going to help reduce the risk. They are recommending in-person ophthalmology visits. I think this is really great that they put this in writing. In the beginning, ophthalmology was trying to do telemedicine, which is a pretty hard thing to do if someone has uveitis. So I'm glad it came out, Special Guidance. Point back to the ACR Guidance. These really should be visits, and we should stay on schedule with them. One thing that we're seeing more and more is increased anxiety and depression symptoms. So sometimes there can be fatigue, withdrawal of interest, low levels of energy, even increased pain reports. And we have to kind of separate what part of that might be related to the really radical changes that are going on in society right now, as opposed to the active disease. We don't know kind of how meaningful that's going to be. Is that going to mean that you're long-term protected? We really don't know yet. So they gave different scenarios and recommendations for different scenarios. So let's say you're a child with juvenile arthritis and you've had no exposure to COVID at all. Then guidelines say let's treat the underlying disease appropriately. So there's no reason to pull back and stop medications if you haven't had any exposure. They do say it's okay to space out monitoring labs. So if you're just monitoring your blood work and you're doing pretty well, you want to make sure your liver enzymes are okay, it's all right to space that out a little bit. And that's actually, I'm glad they said that. That's what I've been doing kind of in my patients to limit coming into hospitals. If you're going to go get a blood draw, maybe do it in a more peripheral place or make an appointment so that you're kind of in and out and not sitting in waiting rooms for a long time. However, if you have a disease like lupus or something like that that we need to do blood monitoring for, it's recommended to continue your normal routine lab monitoring. So for instance, with lupus, we can't necessarily tell if you have kidney disease, or we can't always tell how your labs are going to look based on how you're clinically doing. So we should keep going with the normal routine surveillance. In terms of reducing treatments, again, they're steering people away from this, and I think in my own experience I would agree. I did in the beginning of the epidemic when I didn't know how things were going to play out. If I was already thinking about weaning somebody or decreasing their medications because they'd been stable for a couple of years, I did do so, and I would say a good number of patients did flare and go back on medication again. So that's going to be a case-by-case basis. Now, what happens if you have a close contact in your household who's positive? The ACR recommendations are to continue your medications. I think this is going to be a case-by-case situation. There may be situations in which I would personally say, why don't you hold the medications for a period of a week or 2 weeks and see if you develop symptoms. And if the person in the household has recovered well and they've been asymptomatic, ideally for 14 days, then you're at much lower risk. They do say to avoid high-dose steroids in this situation, which fortunately for us is relatively rare. What happens if you are positive by PCR? Let's say that we start to do these screenings, at regular office visits, and you turn out to be positive, but you have no symptoms. In this case, ACR says go ahead and continue all your medications. Don't change that policy if you're asymptomatic. Keep going the low-dose steroids. So in general, again, summarizing that, talk with your pediatric rheumatologist, but now we have these guidelines. They're helpful to have for overall management. So just to wrap up here, a few little bullet points, and this all comes from our Rady Children's infectious disease docs. Unfortunately, as we probably already know, cases are rising again as the social distancing is kind of getting a little bit more relaxed. This is a virus that is staying for the summer, so we may be seeing more COVID infection and more MIS-C over the rest of the summer. In San Diego, at least, fortunately, we still do not have any COVID-related deaths in pediatrics. I'm not sure if the data in LA or other places. In Rady Children's Hospital, this is our internal data. There's been a good number of patients that have been tested. Out of that, 311, and only 2 patients in the ICU with 0 deaths. So far, and Rady's is doing this COVID collaborative. This is going to allow patients who are coming in asymptomatic and their families to get tested. I think this is a really cool initiative so we can better understand community transmission of this condition.